my honor to introduce our next speaker, Dr. Perry Shieh. Dr. Shieh is a professor of neurology and pediatrics at the David Geffen School of Medicine at UCLA. He received his MD and his PhD in neuroscience from Johns Hopkins University in Baltimore, Maryland. He completed residency training in neurology at Stanford University Hospital and fellowship training in clinical neurophysiology and EMG at Brigham and Women's Hospital, Harvard Medical School. Dr. Shieh's principal clinical interests include myasthenia gravis, inflammatory myopathy, spinal muscular atrophy, muscular dystrophy, electromyography, and muscle histopathology. He has served as an investigator in numerous clinical trials for neuromuscular conditions and has a particular interest in gene therapy. So Dr. Shieh, thank you so much for being here. Today, I'll turn the time over to you.
Well, thank you. Thank you for that introduction. And I'm really happy to be here to tell you about clinical trials for Duchenne muscular dystrophy. I think that there's a lot of buzz that's going on about gene therapy. And so today I'd like to focus on gene therapy clinical trials for Duchenne. But first, I'm going to explain how it works. And then I'm going to summarize what has been seen in the clinical trials, okay? So I just wanted to really quickly talk about Duchenne. I mean, I know that you guys know what Duchenne is. You're living with it or you're living with somebody who has it. But this is just to show you, when we do muscle biopsies, this is what we see. And over here on the left is a normal muscle. And you can see that these muscles are kind of like cylinders there, and they're just kind of cut. So what you're seeing here is a cross section of that. But normal is over here, and a patient with mild muscular dystrophy is over here in the second panel, and a patient with perhaps moderately progressed muscular dystrophy is over here, and severe muscular dystrophy could look like this. I mean, it could even look worse than that. So this gives you a little idea of what we can see on a muscle biopsy. And I think it's helpful because I'm going to be showing you some muscle biopsies a little bit later when I talk about the clinical trials. But, perhaps a child, when they're first born, they might have muscle involvement that looks a little bit more like mild. By the time that they're a few years of age, it may look like the middle, and then perhaps towards and it really depends on the specific muscle, but perhaps more advanced in the disease. The muscle could look a little bit more like this. And I don't think you need to have medical education to tell that this is changing. These white things here are fat. And so what happens here is fat is replacing the muscle. This lighter pink here is scar tissue. And you can see that the muscle fibers, which are here in darker pink, there aren't as many left here, and they don't look like normal shaped. And so very clearly, you can see that there are differences in the muscle. Obviously, we focus a lot on the muscle, but there are other things that can be affected in Duchenne muscular dystrophy. And the heart is, for instance, another organ that we like to emphasize. That's also a muscle, but sometimes we forget it's a muscle. The diaphragm, which helps us breathe, is actually a muscle, but we like to emphasize it because it helps you breathe, and sometimes we need to involve other doctors to help us take care of patients who have breathing problems. And so these are things that can happen as the disease progresses. We can have progressive heart failure, and we can even have progressive respiratory failure or breathing failure. So this is in addition to all the other muscles that we're commonly paying attention to. So this is just to show you, this is a cartoon of a muscle. And you can see that if we were to cut the muscle in cross section, you see these little muscle fascicles and fibers. If you go all the way down to this microscopic level, there are these muscle fibers here. And that's what I was showing over here. These are the muscle fibers. And so each of these has a lot of little proteins in there that help the muscles contract and help them move. And dystrophin is actually an important protein that's around each muscle fiber. And this is another cartoon, and some of you may be more familiar with this than others. This is now the muscle fiber, the outside the muscle fiber, and dystrophin is this yellow protein here, and it links the inside, the intracellular muscle fibers, and it anchors it to the muscle membrane. And so patients who have Duchenne muscular dystrophy are missing this yellow protein. And the gene that's responsible for making this protein is what we call the dystrophin gene, or we usually call it the DMD gene. And so it's DNA that then is a code that helps us make this protein. So patients who have Duchenne muscular dystrophy have mutations in this gene, and this gene, and as a result, they don't make this protein. And as a result, they get this progressive muscle loss. So now we're going to talk about gene therapy. And so the concept of gene therapy is that we are re-engineering a virus to serve as a vehicle to deliver genes back to the patient. So the patient doesn't have the gene or has a mutated gene, so the gene's not working, and perhaps we can replace that mutated gene or defective gene with a new copy of that gene. So that's gene therapy. Sometimes we call it gene replacement therapy. Sometimes we call it gene delivery. It's all the same concept. With Duchenne muscular dystrophy, we've kind of borrowed some of the technology from other diseases that we have treated. And we're using this specific virus that's called adeno-associated virus. So this is kind of a cold virus. It's not a cold virus really because it doesn't really cause the cold, but it tends to be associated with other cold viruses. And that's why the name is called adeno-associated virus, because it tends to associate with adenovirus. And so sometimes we just call it AAV. So the shell of this virus, which we call the capsid, is used as the vehicle to deliver the gene therapy. So the actual virus itself has its own genes, and it helps it to copy itself. The DNA also helps the virus to make its own capsid again. These are viruses which don't seem to cause any disease. They're really small, and so it seems like an ideal virus to use as a tool to treat patients. And so what we're doing with gene therapy is basically instead of having DNA that helps the virus to copy itself to reproduce, we have changed the DNA so that it has DNA of a gene that can help benefit our patients. And it also has other things like a promoter. The promoter basically tells the gene when it can turn on. And so, for instance, if you want to make sure the gene turns on only in muscles, which is what we want to do in muscular dystrophy, the promoter has to be designed to be able to say, hey, only turn on in muscles. So the transgene ideally would be the gene that is missing in the patient. And for patients with Duchenne muscular dystrophy, ideally, we would like to put the dystrophin gene, the DMD gene, into this DNA. The problem is that the AAV virus is a small virus, and it has a capacity of 4,700 base pairs. And I'm not going to go into what this necessarily means. It's just a number, but I will tell you that that is too small to package the whole dystrophin gene into it. So it's small, and the dystrophin gene is 14. So you can see 14 is much larger than 4.7. So we can't do that. We can't take dystrophin and put it into this virus and say, hey, let's treat our patients with this gene therapy. So this is just to give you a little graphic. It's a lot bigger. But we can actually do some little tricks. And so this is a lesson that we learned. This is a paper that was published in 1990. It was a man who was 61 years old, and he had muscular dystrophy, and he had a mutation in the same gene, except we would call him Becker muscular dystrophy because he was still walking. He had some heart problems, But, you know, the fact that he was alive, the fact that he was walking means that his mutation seems to not affect him as much as a Duchenne mutation would. So when they did the DNA testing, they found that he was missing 46% of his dystrophin gene. So a big portion of the middle of this gene was missing. And just to show you what was missing, this is what was missing. So everything from here all the way over to here was missing. And his dystrophin gene looked like this. It's a lot smaller. And so the lesson that's learned here is that, you know, you don't need to have the whole dystrophin gene to be able to help your muscles work. Okay, it's not perfect, but at least it still works partially. So at the time, the sort of name that was coined for this dystrophin was called MiniDystrophin, because it seems to still be functional, it seems to still work, but it's smaller. So I think this is what sparked the idea that perhaps we can engineer the dystrophin gene to make it smaller, miniaturized versions of dystrophin. And those miniaturized versions of dystrophin could still be used for gene therapy. It's not as good as using the whole dystrophin gene, but at least it might have some benefit for patients if we were able to give that to our patients with muscular dystrophy. And so that was the idea, is that perhaps we can make something like this. This is the whole dystrophin gene up here, and this miniaturized version of dystrophin or microdystrophin might still work. And there's been some really fantastic scientific work. A lot of it was done by Jeff Chamberlain, who's listed down here. And he basically took a mouse with muscular dystrophy and gave back various different versions of miniaturized versions of dystrophin to see which ones the mice seem to benefit the most from. And there isn't one answer. It looks like a bunch of them actually really did work. But what we can do is we can fast forward now to 2022. Actually, this all kind of started coming together a couple years ago. And now we have at least 4 different clinical trial programs that are recruiting patients. And over here, you can see there's the Sarepta or Roche program. There's a Solid Biosciences program. Pfizer has a program. And there's a program that's being run mostly out of France that's run by Genethon. And they all do it a little differently. Okay, so, you know, and they have for instance, they have different promoters. These promoters, once again, tell us when to turn on the gene or tell the gene when to turn on. These are all different ways of basically saying we want to turn on in the muscle and in the heart because it affects the heart as well. They have different transgenes. So the MiniDystrophin or microdystrophin is a little bit different, but they've all been shown to work in animals. And so they all, you know, have very good promising data to suggest that it's going to work. And then the different virus capsid that's used is also different. You can see 2 of them are the same, but the other 2 are different. So the ingredients that go into this recipe, so to speak, are a little bit different, but they're all aiming to do the same thing. They have a vehicle, which is the virus vector, the capsid, that contains this DNA, and this DNA is going to turn on and make this miniaturized version of dystrophin, mostly in the muscle and the heart. So that's the idea. This is the concept. So what I'd like to do is now talk about how we do clinical trials. When we do clinical trials, we want to see if a drug works, because now we have an idea that seems to be very promising. And these are the things that we want to see in Duchenne. First of all, we want to make sure it's safe. And so any types of side effects, any hospitalizations, any deaths, you know, if they do happen, you know, can we figure out what's going on, if that's attributable to treatment, or sometimes it's just from the disease itself. And then we want to see if the patients are better. And so, in a muscle disease, usually we try to measure muscle strength or how well a patient is able to move. And we have a few different assessments. I'll talk about what the North Star Ambulatory Assessment is in a little more detail because that's not obvious. But time function test is obvious. How long does it take to run down the hall 10 meters? How long does it take to get up from the floor if you're lying on the floor? So these are time function tests. We can also test breathing function. And there are some of the data that's also designed to look at that. We also want to see if dystrophin is being made in the muscle. And so this is what we call dystrophin protein expression. So we are giving gene therapy to make dystrophin. And so in many of the clinical trials we're doing muscle biopsies. And we might do them before the child gets treatment and then after the patient gets treatment. And then we can compare to see if the dystrophin protein is there, if it's being increased by the treatment. And we have a couple of different ways to measure that. We can just take the whole muscle and measure it directly. And that's what Western blot and mass spec do. And I'll show you some of the information that's come up from the clinical trials for that. We can also do what I showed you earlier, which is look at the muscle biopsy under a microscope and see with staining if there's dystrophin in the muscle. And I'll show you some pictures of the immunofluorescence. It'll make a little more sense once I show you the pictures. Okay. And then we can also see if the DNA is finding its way into the muscle. So this is that test. It's called the North Star Ambulatory Assessment. And this is what we're asking our patients to do, to stand, walk, stand up. This is for boys who can walk. So that's why it's called an ambulatory assessment. So for the patients who can't walk, we have to use a different test. But basically, we can score them 0 to 2 on these 17 different items. So the maximum score is 34. So the better the patient is, the higher the score. And this is in increasing difficulty. So hopping is more difficulty than getting up from the floor, for instance, or just walking. And what we find is that if you take a large group of Duchenne patients, you can get an idea of what patients with Duchenne typically look like. Each of these gray lines is an individual patient. And of course, you can't make out some of the lines because there are so many patients in this study. But that's good. This was published a couple of years ago. It gives us an idea of if you were to look at this test, this North Star Ambulatory Assessment, how Duchenne muscular dystrophy patients typically do without treatment with something like gene therapy. These patients were mostly on steroids. And so if you have a boy who's been treated and his line looks very different, like his line starts to go upwards, then that would be very, very promising. That would be a good sign. All right, so this is a slide that summarizes all the gene therapy studies that have recruited or are recruiting or soon will start recruiting. So again, this is the order. This is the Sarepta program. And typically we go through phase 1, phase 2, and phase 3. Earliest studies are phase 1. And they're solid, Pfizer, and Genethon, as I showed you earlier. But each of these is a study. So there was in the Sarepta row, there's the 101 study, the 102 study. These were the first 2 studies. Then what happened was Sarepta said, well, we're going to change our manufacturing so we can start making it in large scale. So they had to go back to a phase 1 study that's called Endeavor. And so that's what's shown over here. And then the study that recently opened is Embark. That's a phase 3 study. And then there will be a study probably later this year called Envision that's geared towards non-ambulatory patients. So Embark is young patients that are ambulatory. Envision actually will recruit some ambulatory patients a little bit older, as well as older non-ambulatory patients. And that's going to start probably in the next few months. Solid Biosciences has a study, and I'll show some of this data in the Ignite DMD study. Pfizer has 2 studies. They had an early study, which we do have some data from, and then they have a phase 3 study. And then the Genathon study, I think they've only dosed one patient as far as I know. I don't have really any data for that. So today I'm going to show mostly data from Endeavor, Ignite, and then this phase 1 study. I'll show a little bit of data from the 101, 102 study. The phase 3 studies are too recent that we don't have any data for it. Okay. But this will give you a little bit of an idea of what's happening. Okay. So first, let me just summarize some of the highlights of the Sarepta Roche program. So first of all, this is just some data from the muscle biopsies that shows that before these boys got treated, there was no DNA in there. That's no surprise. And then after these boys got treated, there was DNA. There was MiniDystrophin or microdystrophin DNA in there. When they looked at the protein, they also showed that it went from 0 to about 55% of what normal should be. So it's not 100%. You know, on average, it's about 55%. There's certainly some range. There are some patients that have a lot of protein, and there are some patients that have a little less protein. But the average is kind of at about 50%. Now, I promised I was going to show you some muscle biopsies. And so this is immunofluorescence. So basically, we can stain to see if there is dystrophin there. Normal should look kind of like something like this here on the left, but that's not dystrophin staining. But in the middle here is what this particular patient looked like. Before he got treatment, there was no staining whatsoever. And then after he got treatment, and this is 12 weeks later, you can see that a lot of the muscle fibers were now staining for dystrophin. Not all of them. You can see there are a couple here that aren't staining at all or not staining very well. But this indicates that the virus did what it was supposed to do. It delivered the microdystrophin or minidystrophin DNA into these muscle fibers, and the muscle fibers are now making the protein. And they can quantify this. So if you look over here, this is just looking at a couple of different ways. They can say how many fibers are staining positive, and you can see clearly before the patients got treated, it was almost none. And then after the patients got treated, the number of fibers that were staining red now were much higher, up to 70%. They could also look at the total light intensity, how much red there is, and certainly that was also an increase as well. So this is some data from one of the Sarepta studies, but it gives you an idea that when we're saying, is the protein being made, I can show you pictures that potentially can help you understand how we're able to measure that. Now, this is looking at strength or benefit, clinical benefit. This is that North Star Ambulatory Assessment test that I talked about earlier. So those 17 items, maximum score once again is 34. And these were the first 4 patients that were ever dosed with the Sarepta Roche drug. And you can see there is somewhat of an increase, and we usually don't expect a whole lot of an increase, although patients can improve a little bit. But certainly it is in the positive direction. So this is at baseline, so prior to treatment. The next column is at year 1, year 2, and year 3. And so this is patient 1, patient 2, patient 3, and patient 4. These 4 patients, year after year, seem to have some degree of improvement. Maybe the first one had a bump in the first year, but then kind of started to taper down after the second and third year. But the second patient, the third patient, and maybe to some extent the fourth patient also those all had some improvement over time. This is another study. This is the Endeavor study, and you can see that there was, in general, if you took these 11 patients, they generally were improving on this North Star Ambulatory Assessment. So these boys appear to be doing better. But here's some of the safety information. So you can see that vomiting was pretty bad in a couple of patients. There was some liver effects as well. This is what transaminases and liver injury are. There were a couple of patients that had some muscle breakdown. That's what rhabdomyolysis means. And then there are two particular things. One, I'm going to really talk a bit about called immune-mediated myositis. That's where the immune system appears to be attacking the muscle. And that seems to have been triggered by the gene therapy. So I'll talk a little bit more about this towards the end of my talk. And then there's myocarditis, which is inflammation of the heart. Let me move on to the second clinical trial program. This is the Solid Biosciences program. So this is a relatively smaller program. It's only recruited 9 patients so far, and only 6 at the higher dose, which they think is the optimal dose. And so patients 4, 5, and 6 are the first patients that they had on the earlier dose, on the higher dose. And you can see that this is a muscle biopsy. It's kind of similar to the ones that I was showing earlier that shows that there's increased red here, showing that dystrophin is being made in the muscle. If you look at patient 5 over here on the right, you can see before he got treated, it was all black. And then after he got treated, it got a lot redder. Not every muscle, but a lot of muscle fibers are staining red. They basically stayed at somewhere between 50 to 70% for this patient. And it seems to also improve the proteins, a lot of other proteins that dystrophin works with. And that's what they're showing over here. And if you look at how these patients are doing, there are 5 patients that were able to walk at the beginning of the study. And what you can see is this purple one may not be doing as well, but then this other purple one seems to be improving, and these blue ones seem to be flatter than the average curve that's shown here in black. And this is just at a later time point. You can see this first purple one actually seems to be doing better now. So these purple ones seem to be doing better than what we would expect typical Duchenne patients to do without treatment. And the blues, I think, also seem to be perhaps doing better. Maybe not so much this one here, but the other 2 appear to be doing better. So this is how we use this graph, because if the lines kind of deviate from what we think the average is, then that might be potentially a suggestion that the patient is doing better than typical. And this is another way we can measure. We can ask our patients to walk for 6 minutes and see how far he can walk. And you can see that we also have a curve, what typical Duchenne patients look like. And then if these individual patients shown here in blue and purple look a little bit different, then they might be doing better than the typical Duchenne patient. Pulmonary function, so this is the ability to breathe. We sometimes measure what's called a forced vital capacity, which is how much air our patient can breathe out. And so we can measure those numbers. The less you're able to blow out, then the more likely it's a suggestion that there's weakness in the muscles, the breathing muscles. And you can see that in these patients that got treated, they all tended to be improving, maybe not patient 3 so much, but patients 1, 2, 4, 5, and 6 appear to be improving. And this is compared to patients who are not treated. Now, with regard to side effects and safety, there is some things to talk about. There were a couple of patients where the platelet counts dropped quite a lot, and that led to as well as anemia and some kidney damage. And so this is a syndrome that we call TMA. And of course, we do have treatments for this form of TMA. But of course, very commonly, patients with TMA do need to be hospitalized. And it turns out that the patients in this clinical trial did eventually make what appears to be a full recovery. But nonetheless, this is a serious event that we're watching, and this is something that we're becoming more aware of with gene therapy. So overall, the side effects, the other side effects, nausea, fever, and vomiting, which we are seeing quite a bit with gene therapy. And so finally, I'm going to talk about the Pfizer study, just the earlier one. And so this study has 19 patients, at least 19 ambulatory patients. 3 were dosed at the lower dose, and the other 16 were dosed at the higher dose. And, I'm showing a lot of muscle biopsies, but I think it's helpful to see that these 3 patients here, I think these are patients 4, 5, and 6, before they got gene therapy, they basically were not staining anything at all. So there's almost no dystrophin that's being made by this patient. After these patients got gene therapy, 2 months after, you can see there's a lot more red. And then 12 months after gene therapy, these patients appears to be making even more dystrophin than even 2 months. But this gives you a little idea of the pictures that we can look at to see how much dystrophin is being made in our patients' muscle biopsies. This is just to show you in graphs. You can see that there's no dystrophin that's being made prior to getting gene therapy. 2 months later, they're making dystrophin, and there's a bump, and it appears that the dystrophin increases perhaps even further at the 1-year mark. And this is looking at the total dystrophin protein. If we just quantify, the muscle, we can also look at the muscle biopsies that I showed you earlier and look at staining, and the number of fibers which are staining also appeared to be increasing. And here are the numbers. You can see by, the technique we use is mass spec. At 2 months, it was 22% of what a normal person would have, and this is 22%, and then 40% of normal at 1 year. And if you look over here, it's 0 at baseline, and then 39% at the 2-month mark on average, and then 62% at the 1-year mark. So how are the patients doing? Well, again, you can look at the North Star Ambulatory Assessment, and the patients who got the lower dose are shown here in this bluish purple. And then the other patients at the higher dose are shown here in green. And you can compare to what a typical Duchenne patient might look like, approximately in the same age category. The data that's shown here in gray is the average of how patients typically change over a year. And they took this data from another clinical trial, but took the placebo group. And so comparing the patients in this gene therapy to this other control group, you can see that in the 6 to 7-year-old patients, they appear to be doing better than the gray box. The 8-year-old patients may be doing better than the gray box. Certainly these 4 seem to be doing better, maybe not so much this one over here. The 9-year-old possibly doing better as well, and the 10 to 12-year-olds, slightly better perhaps than the typical Duchenne, at least represented by this clinical trial. But if they were to just sort of show what the distribution looks like, the patients in the study were over here on the right, generally maintaining their motor skills, whereas the patients in the external control group, so untreated, were doing worse. And this just breaks it down by 6-minute walk distance treated versus the external group of untreated patients, breathing function, upper limb function over here in the middle, and a couple of other specific time function tests like rising from the floor, 4-stair climb, and 10-meter walk run. Generally, the green is doing better than the gray. Now, with regard to safety, there are also some patients that developed acute kidney injury and drop in platelets. There were a couple of them. And there was vomiting and nausea and fever as well that was seen in this group. It is important to point out that this is only among the 19 ambulatory patients. There was actually one patient who was non-ambulatory that actually passed away shortly after getting gene therapy. So he was an older patient. He was 16. So he's not included here in this analysis, and it's not clear exactly if his non-ambulatory status may have contributed to his death. And I think that's still under investigation at this point. But I do want to mention something because this is important. There's something called anti-transgene reaction. And so, and I'm highlighting here, I talked about this earlier, there was this immune-mediated myositis. So basically, this patient had a very large deletion. His mutation was very big. And it's now thought that perhaps what's happening is that his immune system had never seen these portions of dystrophin. So when he got introduced to microdystrophin, he was being exposed to new proteins that his immune system had never seen before. And so these new protein sequences then caused an immune reaction, which then reacted against his muscle. So, and similar events were actually seen in the phase 3 Pfizer study. I didn't show the data from this, but I do know that they had a couple of patients that had this problem too. So this is an autoimmune reaction which appears to be triggered by the microdystrophin or MiniDystrophin that we are giving to the patient. So that raises some concerns. So is it possible that by introducing these transgenes that we're going to cause the immune system to attack the muscle? And so we are now worried about this. And so this has led to exclusions. So patients for the Sarepta Roche studies, we are basically at this point, we're excluding patients who have mutations between exons 1 through 17. This is based on some recommendations from a group of scientists that are advising on the study. And for Pfizer, at this point, they have decided to exclude any mutations between exons 9 through 13, as well as large deletions that include 29 and 30. So not all patients with Duchenne would necessarily be a candidate for gene therapy. And we will have to see what the other programs, like Solid has not announced if they're going to have exclusion criteria and what those exclusion criteria will be. But so it is important if you're looking at your son's mutation or that you do know your son's mutation and you understand what you know, if this may potentially be exclusionary for receiving these forms of gene therapy. I'd also want to make sure that we have an understanding of what is a reasonable expectation. So if our patient with Duchenne muscular dystrophy is walking, you know, we wouldn't necessarily expect the benefit to have a dramatic effect where they'd be walking better or even running. We're really looking at preservation. So preservation of walking, preservation of breathing, preservation of cardiac function. That would be a potential realistic expectation. And, you know, realize that what we're introducing with gene therapy is not a perfect version of dystrophin. It's a miniaturized version of dystrophin. So it's something that probably will progress with time, even if it works exactly the way we want it to. So, and so we may still get some gradual progression and loss with time. Hopefully it won't be very much. And early ambulatory, non-ambulatory, we want to preserve, for instance, the arms. You know, our patient is no longer walking, but, you know, at least if we can help to keep the arms working, you know, we wouldn't expect necessarily to start walking again. Okay. And then preserving breathing function, preserving cardiac function. And likewise with late ambulatory, if your boy is older and he's lost a bit of function, you know, we would just want to be able to preserve what there is and not necessarily regain function. So in summary, there are now 4 clinical trial programs. I've gone into some detail in 3 of them, and we're giving what we call AAV-mediated gene therapy, gene transfer therapy. And now I hope you understand what I mean when I say microdystrophin or MiniDystrophin. And these 4 programs have recruited patients. Data from muscle biopsies in the first 3 programs do show that microdystrophin or MiniDystrophin is being made in the muscle. And the clinical data does look promising. It seems to be better than the natural history in general, although I think we need more data. We need long-term data and we need more patients for us to know how much of a benefit. Of course, we're concerned about the immune system because the immune system can get in the way. It can cause side effects. It can sometimes cause severe side effects. In some cases, it can actually prevent the gene therapy from working. I talked about, the anti-transgene effects that could be a problem. So this is my last slide. What do I need to know about gene therapy? Well, really importantly, there are risks, and the risks are real. I think I've given you a little bit of an idea of the fact that the immune system plays a significant role in some of the risks that I'm talking about. And at this point, we're still not clear exactly why there was one death in the non-ambulatory patient in the Pfizer study, and hopefully we'll learn more about that as well. Another thing is it may not be available for everyone because of the anti-transgene effect that I talked about, the fact that the immune system might even attack the dystrophin, the microdystrophin protein or the mini-dystrophin protein that we've introduced. That could be a problem. And so we are hopefully going to be able to understand that and maybe get around that. But at this point right now, the gene therapy programs are talking about excluding certain patients because of this problem. And finally, although this is a promising approach, and I do believe that the patients are doing better, it's not a cure. Okay, it's not a total slam dunk. First of all, we know we're not introducing the whole dystrophin gene. We're making a miniaturized version of dystrophin, which is not as good as the whole dystrophin. And we have to make sure that whatever we're doing also is finding its way to the right tissues and doing all the things it's supposed to be doing. But I hope that this presentation has given you a little idea of what gene therapy is, given you some important data and information about how we're looking at patients who've been participating in the gene therapy, and I hope it helps you make decisions as to what you would like to do with gene therapy. And that's it. I thank you for your attention, and I'm happy to take questions.
Thank you so much, Dr. Shieh. So interesting and just a lot to digest. So thank you so much. It does look like we have a few questions, and for those that haven't submitted their questions yet, please go ahead and do so now, either using the chat or the Q&A function. But let's get started with a couple questions. So somebody submitted, how often after the initial tests are tests ran again to determine muscle regression?
So in the beginning, we're seeing our patients quite frequently. We don't test the muscle strength every week, for instance, even though sometimes we're seeing them every week. But in general, in the first year, we're oftentimes testing them every few months, every 3 months. And I don't know that we need to look more frequently than that. It's, what we really want to do is understand how our patients are doing over the long term. And so the long-term data may potentially be the most important part of what comes out of these gene therapy studies.
Next question, does the advancement of the disease depend on the gene?
So I think the question is asking, does the efficacy of a treatment depend on the specific mini-dystrophin or microdystrophin that's being used? I think we believe that that's possible. Maybe some microdystrophins might be better than others. At this point, we don't have any information that suggests one is better than the other. So I think that's answering the question. I'm not sure if I answered the right question.
Another one came in. I'm assuming they're asking, will boys still have to be on steroids even if after gene therapy?
So yeah, we're trying to understand that better. If this were a cure, then the answer would be no, but it's not a cure. And so I think for many of my patients, I have actually tried to lower the doses of steroids, and ultimately we ended up not doing that, we went back up on the steroid doses for most of our patients. So I don't think steroids are going to disappear anytime soon.
Another question, and you might have answered this, but how and when can patients receive gene therapy, and will an individual need to be ambulatory to receive it?
So that's a very complex question. So I think most of us believe that gene therapy benefits younger patients the most. I don't know how young is young, but if you're younger when you receive gene therapy, you're more likely to preserve muscle. It's likely to benefit older patients. It's probably likely to benefit patients who are no longer ambulatory. We may need to prove that, and there's at least one study, the Envision study that I briefly mentioned at the beginning, which is trying to answer that question. However, there's another concern, which is it more dangerous to give gene therapy in older non-ambulatory patients? And some of us do think it might be. And I think that there was one death in a 16-year-old in the Pfizer study, and at this point, we don't know if that was because the age increases risk for receiving gene therapy. So I think we'll know more in the future, but at this point, I don't think we can answer that question very well.
Sure. And then another question came in. I think you answered this one as well, but is everyone eligible? It's usually based on the genetic mutation and what's out there, correct?
Yes. So the genetic mutation at this point, they're likely to prevent certain genetic mutations will probably prevent some of the patients from receiving at least certain forms of gene therapy. So Pfizer, for instance, has different rules than Sarepta does, and it's because they have different scientists consulting them. But it's all based on the same idea that the immune system might attack the gene therapy protein.
And then with gene therapy, how often does somebody receive it?
So gene therapy is a one-time treatment. We only give it once because once you've had gene therapy, your immune system will now remember the gene therapy. So it's like an infection. So now you're immune against the gene therapy, and you can't be sort of infected again with the gene therapy. You can think of the gene therapy as an infection. So we can't give it again. There are some people who are wondering, is there a possible way to give it a second time? Maybe if a boy received gene therapy a second time after he's received it, there'll be some benefit to that. I think that that's possible, but we have to figure out how we can get around the immune system the second time. And there are a lot of people who are thinking about this. We don't know what the right way to do it, or if it is actually possible at all.
So interesting, and thank you. I'm just checking the chat one more time to make sure we covered all the questions. I'm not seeing anything else coming in. So thank you, Dr. Shieh. We'd like to, we just are very grateful that you could be here today. We know you're so busy, and we appreciate the time that you've taken to speak with us today.